please write your questions in the chat or raise your hand. And please mute your microphone during the whole presentation. For those that you are just joining us, welcome again, and we are ready to start to review COVID-19 in pediatric patients. So Syndie, thank you very much.
Thank you for your introduction, Claudia, and good morning to everyone. I will start presenting you on COVID-19 in children, and we will talk about mondial statistic, global statistic, and for AD statistic as well. And today's goals are to identify the clinical presentation of COVID-19 in children and neonates, recognize the potential complication of this pathology in children, and promote the role of prevention among children. To be covered today will be a slide introduction that I'm already doing, the epidemiology in children globally and in Haiti, transmission in children, the physiopathology, the clinical presentation, the clinical cause and complication, diagnosis, treatment and prevention, and the takeaways. We will be two presenters. I will be the first one, and then for the physiopathology and the clinical presentation, we will have Dr. Taina who will work with us. As we all know, the COVID-19 pandemic started in December. It was declared a pandemic by the World Health Organization in January. But we used to have the coronavirus at the beginning since 1960 in the world, and that after that, 6 types were identified as potential agents for respiratory pathology in children and in general human population. And this coronavirus at the beginning was in charge of respiratory symptomatology in children and less than 5, and also immunocompromised people, and it was responsible of very severe respiratory disease. And among children, usually the infections today are fewer than in adults, but at the beginning it wasn't the same. The situation now is that the human coronavirus in children is a new pathology, and the symptomatology is not specific, and there is no definitive protocol for the care and treatment. But today, the adults are more concerned by this disease than the children. For example, as you can see on the slide, in the States, 2% of the confirmed cases were among children. China, it's slightly the same. Italy, it's less than 2%. Spain, less than 1%. And in Haiti, it's 2.7% of prevalence in children. Just to confirm what we were saying for Haiti, as you can see, the prevalence is very low in children and the mortality as well. In Haiti, we only have one hospital only dedicated to children. And in this hospital, as of March 27, 40 cases were confirmed, over 173 suspicion of cases for COVID-19. 34 were diagnosed, and 23% required hospitalization. And as you can see, boys were more concerned than girls, and the median age for this population was 2 years old. Among this number, 179, 34 required hospitalization, but 75% of children who require hospitalization are subject to a comorbidity. It can be like a respiratory comorbidity like tuberculosis. As we all know, tuberculosis is endemic in Haiti. And sometimes they do have cardiac pathology like cardiopathology. And 3 deaths occurred in this hospital, meaning 40% of the total hospitalized children. The clinical manifestation in Haiti, as we said at the beginning, the clinical manifestation for COVID-19 are not specific. We can have different, it's very polymorph pathology, we can have different manifestation, but the most current in Haiti were fever, dyspnea, and cough. And we will deepen this more with Dr. Brice lately. At the hospital, the Saint Damien Hospital, as I was saying, we receive children with COVID-19 and they have comorbidities. Just to highlight what happened in one case that they received there, and usually this is the common way that children will come at this hospital. One child came at 8 months old to the ER with 3 days of fever, dyspnea, and cough. She had no other medical history at that time because she didn't have any comorbidity, she didn't have any cardiology, nothing. But as you can see, in a developing world at 8 months old, she only received the BCG vaccine. There was no clear contact for that child with the parents or any adult with COVID-19. The vital signs showed fever, dyspnea, high accelerated heart rate, oxygen saturation was normal. At the physical exam, they found dyspnea with the sign of dyspnea in children, like nasal flaring and chest indrawing, crackles in the left lung, no sign of dehydration, abdominal distension. The clinical diagnosis was a bacterial pneumonia, and they had to think of COVID-19 in that case. They started the management with ceftriaxone and vitamin C, and they performed the lab. The baby was anemic, the white blood cells were high, and the C-reactive protein was 24 milligram per deciliter. The blood culture was negative. After 2 days of hospitalization, the baby was afebrile, and the dyspnea went away after 3 days. But during the hospitalization, the test for COVID-19 was positive, and after 5 days, the baby was discharged, which this case confirmed the fact that in children, the COVID-19 pandemic, the COVID-19 manifestations are very mild. Usually, children with comorbidities like tuberculosis or cardiopathology, they will be more likely to have severe symptomatology of this disease. And this is where the deaths are going to occur. When they are hospitalized with comorbidities, they will have more chances to die of COVID-19. And remember, this pathology in children will induce less symptomatology and fewer hospitalization in children. I will ask Dr. Brice to continue with the symptomatology, with the clinical manifestation of the pathology. Taina, you may continue.
Yes. Thank you very much. Let's see. So as Dr. Saint-Hilaire said, children have less severe manifestation for COVID-19. The studies have shown that minority of children with COVID-19 required hospitalization and very few of them required intensive care. And most of them had underlying condition, like in adults with a higher rate of hospitalization and intensive care unit admission. Can go to the next slide, please. In a study that has been made in Europe in children and adolescents, it has been proved that for the transmission of COVID-19 among children in, okay, we will stay, sorry. Yes, as we were saying about the comorbidities in children, and we are really sorry for that. Yeah, we will continue with the transmission of COVID-19 among children. So in most cases, transmission of COVID-19 among children has mostly been proved that it had made by household exposure, usually from an adult index patient. It also has been proved that caregivers and healthcare associated outbreaks have been reported. In some studies in the United States, most of children, more than 90% of them, were affected by household contacts with previously affected adults. We often ask ourselves, how contagious is COVID-19 among children? It has been proven that children are bad transmitters of COVID-19. The reason the theories that has been proven is maybe because of the less severe manifestation, and also because of the viral interference in children. So direct transmission child to child or child to adult has been proven to be weak, and the most common way of transmission in children is by indirect transmission. For the newborns transmission, there's a few studies that has been prove that the most way of transmission of COVID-19 in newborns is via respiratory droplets when the newborns are exposed to infected mothers, like when they are breastfeeding, or caregivers, or also healthcare staff. But for the transmission, they're among newborns by intrapartum, peripartum, or possible vertical transmission. There are less reports that have been proven, but there are some studies that have proved that newborns at 1 day, 24 hours of life, or 48 hours of life have been tested positive for COVID-19 with the PCR test. That doesn't exclude totally the possibility of intrapartum and contamination. For the pathophysiology of COVID-19, we know that COVID-19 associated infection induce a lot of immune responses in our body, but we won't stay on this slide. We wanted mostly to put the accent of why the children are poor transmitters or less to have severe form of COVID-19. There are some potential factors that have been proven to protect children against severe form of COVID-19. There are three main potential protective factor. The first one is the prevention of the virus exposure that has been made by the early isolation and movement restriction by closing schools and daycares early. The second protective factor that has been proven is the children has appropriate infection handling by trained immunity that is a strong innate response to infection in kids due to vaccination, principally live vaccine, and frequent virus infection. The second theory is about the high ACE2 enzyme expression in kids that has been proven to reduce the inflammation in the lungs in children. The third theory is about the lack, since children are young, they have a lack of immune senescence and a good lung regeneration capacity. And the third protective factor that has been proven in children is the, we won't say absence of high risk, but the less degree of related comorbid disease or other risks like smoking or obesity. For the clinical manifestation of COVID-19 among children, the symptoms, the general symptoms are pretty much the same in adults, but as we have said in the beginning, with less severe cases and some rare manifestation. As Dr. Saint-Hilaire has said in the beginning, children mostly present with fever, with upper respiratory symptoms like fever, cough, nasal congestion, sore throat, and the loss of smell and or taste is less common. In infant, we can have also gastrointestinal manifestation like diarrhea, vomiting, poor feeding, or poor appetite. And it has been proven that the incubation period goes to 2 to 10 days and can extend to 14 days as for adults. As we have said, that children can present with less common symptoms. It also has been proven that children can also have cutaneous findings like maculopapular rash or urticarial rash. And also the most common one is what they call the COVID-19 toes, which consists with a reddish purple nodules on the distal digits, as we can see in the picture. But there are also a lot of studies, a lot of reports that have proved that children, a large group of children can present also asymptomatic infection. For the clinical course and evolution of the COVID-19 in children, as we have said that there are few classifications that range the clinical evolution of COVID-19 in children to different levels of concern. It can go to asymptomatic to critical manifestation. Asymptomatic children, which is one of the less form of manifestation with no clinical signs or symptom. The mild one with a few fever, fatigue, or myalgia. The moderate one with children presenting with pneumonia in 39% of cases. Severe children with sign of hypoxia, and the critical one, children who present with acute respiratory distress syndrome or respiratory failure, shock, or multi-organ dysfunction. This one is the less common one with 0.6% of cases. There's another classification, but pretty much the same, that also goes to mild to critical level of evolution. The mild, as we have said, with no symptoms, severe with lung involvement, hypoxia, and critical with acute respiratory failure, shock, and multi-organ dysfunction. As we have said in the beginning, children can also present with atypical form of COVID-19. It has been proven, and there also has been death reported by the CDC of children presenting with meningitis, with status epilepticus, and who has died of COVID-19. One of the most important part of the clinical presentation in children is a rare form, but that has now there's a few more cases now of multi-system inflammatory syndrome in children associated with COVID-19. There are cases that have been proven in the United States, in Europe, that has presented mostly in children over 5 years old and who mostly present with prolonged fever and other symptoms like myocarditis and Kawasaki-like syndrome that we will see in the next slide. As we have said, as we saw in the beginning, also for the multisystemic inflammatory syndrome associated with COVID-19, there is a spectrum of range that goes to mild to severe form of multisystemic inflammatory symptoms. Now, the severe one is mostly in children who has Kawasaki-like syndrome or elevated markers of inflammation, multisystem involvement, cardiac involvement, and shock that are pretty much common in this form of severe multisystemic inflammatory syndrome in children. For the frequency of the presenting symptoms in children with MIS-associated COVID-19, the most common presentation is the persistent fever that lasts more than 4 days, some gastrointestinal symptoms in 60 to 100% of cases with abdominal pain, vomiting, diarrhea, the rash that we saw before, conjunctivitis in 45 to 81% of cases, and other manifestation like neurologic manifestation and sore throat and others. Those children can also present with a clinical presentation of shock that is common with 48 to 80% of cases, and how we said with criteria of Kawasaki-like syndrome that we will see in the next slides. So for the multi-system inflammatory syndrome associated with COVID-19 in children, there are 2 classifications that have been made. The first one is by the CDC that is based on 4 criteria. And as we can see, all 4 criteria must be met for that diagnostic. Now, the first one is based on the age of the patient less than 21 years old. The second criteria is based on the clinical presentation with that including the fever, as we said, some laboratory findings like elevated markers of inflammation. The children who present with severe illness requiring hospitalization, and also the involvement of 2 or more organ system involvement like cardiovascular, respiratory, or renal involvement. The third criteria that is really important is it has to be exclude that there is no alternative possible other diagnostic. And the fourth one is the recent or the proof of recent or current infection of COVID-19 in this child. The whole classification is pretty much the same, but it has been divided in 6 criteria that all 6 also must be met. Now, the first one, we can see that the age is pretty much the same, but goes to 0 to 19 years old. The fever has to last at least for 3 days. The clinical sign include signs of multi-system involvement like rash, hypotension, or shock, and also laboratory finding like the markers of inflammation, and it also must be documented that there are no other obvious microbial cause of inflammation or bacterial sepsis. And also we have to have the evidence, the proof by PCR or serology that the child has a last or an actual infection of COVID-19. For the testing, as you can see, we can have a majority of tests that can be done, but the most important one consists of the reverse transcription polymerase chain reaction, the RT-PCR, that will confirm the diagnostic of COVID-19. This test can be made also in newborns, but it is proven that it's better to do it in the first 24 hours of life or 48 hours of life in newborns that are born with mothers with confirmed or suspected COVID-19 infection. For the, because of the less proof possibility of testing in some countries, the Infection Disease Society of America guidance has made some criteria based on priority for testing in children. So this guidance goes to the first or high priority to the fourth or less priority of testing. The first one, the high priority one of testing, is for children with critical ill receiving ICU level care with unexplained viral pneumonia or respiratory failure, or children with fever or symptomatic respiratory symptom of tract infection, with close contact with patient with confirmed COVID-19 infection in the last 14 days. Children also with fever or lower respiratory symptoms that are immunosuppressed, compromised, and also people working in that has a high risk of to be critical to the pandemic, like healthcare workers or public health officials. The second priority is for people that are hospitalized but not in ICU, with long-term case with unexplained fever or respiratory symptoms. The third level of priority is for an outpatient who met criteria for testing, influenza testing. And the fourth one is for people that have criteria for community surveillance and direct public health. Also, for the diagnostic of COVID-19, imaging can play a role in the diagnostic, but it is important to note that chest CT or chest X-ray are not alone recommended for the diagnosis of COVID-19 in children. In those images, we can see that X-ray has pretty much shown patchy infiltrates consistent with viral pneumonia, and the CT that we see in the next slide that showed also ground opacities is also images that we can find also in adult and infant, but as we have seen, X-ray and CT are not only for the diagnostic of COVID-19, or not specific for the diagnostic of COVID-19. And for testing in children presenting with the multi-system inflammatory symptom associated with COVID-19, and it also has been made echocardiogram that can show depressed function of the left ventricle or coronary artery dilatation and other findings that can be found. And sometimes they also use chest X-ray, chest CT, and also abdominal imaging like ultrasound or CT.
Hello? Hello?
It looks like we lost Taina.
Did we lose Dr. Brice?
Yes.
Okay, let me continue. There are no specific drugs approved in the US for the treatment of COVID-19. And I think that the protocol all around are the same. We start first with the supportive care, and then we use the antiviral therapy and adjunctive therapy. For the supportive care, we do IV fluids and electrolyte support, empiric antibiotics as azithromycin or clarithromycin. We do use the antiviral therapy, but we don't really use a lot of hydroxychloroquine in Haiti, but we do use blood thinner. We do use some adjunctive therapy like the cortisone. We do dexamethasone. So we all know that the treatment are not definitive in COVID-19. So the protocols are still under evaluation, but the most that we do are IV fluids, some antibiotics, plus drug thinners, and then the general adjunctive therapy like the positioning, like the therapy, the clapping therapy that we do for the patient. And then currently they are starting to add the corticoids, the steroids to treat COVID-19 in Haiti. And as we all know, CMMB is working a lot with the community because we do have a lot of community field agents like the community of workers. We call them the ASCP, who do the home visits in the communities and work with the families. Although they are not directly providing care and treatment to the community, but they are trained in helping people, in helping the families to take care of the patient. And during the home visits, they perform the communication for hygiene, for hand washing. They do that as long as they have to visit the families. They help to disinfect the surfaces, which is the requirements from the WHO. And they do practice, in Haiti, they do not practice the respiratory hygiene, but it is indicated that people visiting families do that. And also they have to maintain the social distancing that is being required, 1.5 meters. It is the same everywhere. And we should remember that symptomatology, respiratory symptomatics can be from other conditions, that they cannot stay home with the symptomatology of respiratory disease at home. They need to consult, they need to look for further help at the health facility. And also the community of workers must know that they should complete the protocol for ICCM for all children with fever and suspected to have COVID-19 in the community. And after completing this assessment from ICCM, they need to activate the local protocols for children suspected for COVID-19 with the health facilities help, so they can refer the children or continue the care at home protocol that we have. In Haiti, we do have a care at home protocol for children or for adults, meeting criteria for that protocol. So this is like a summary for care and treatment for children at community level during a COVID-19 outbreak. So we need to screen first for COVID-19 according to the national protocol that is in application in your country. So we do the social distancing, and we ask for the history of the pathology with the family. What are the signs? When did that happen? When did that start? We need to complete the ICCMB for activating any COVID-19 protocol. So the community of workers should be well equipped to go and visit this family, because if they think that there is a COVID-19 pathology ongoing in the house, they need to protect themselves to continue the work. So if they are well equipped, they can start with the activities. So they can start with the training, the in-house training about hand washing, and they need to wear their protective personal equipment. They need to change their gloves, so they need to be well equipped to do that. And they need to give the treatment that they can do for the standard ICCM protocol. Usually it is in Haiti, it should be the how do we say that? The fever, antipyretic medicine they will start with, and then they will refer the patient. So they activate the local protocol, which is to inform the health facility, which is to do the contact tracing and to isolate the family and the suspected patient, either at their house or in a specific place designated for this. If the patient is not COVID-19, if there is no COVID-19 in the house when the committee of workers do the home visit, they will continue to do everything that they should do during a home visit. Apply the standard ICCM protocol, like doing education, continue the education about hand washing, about wearing masks, about respecting the social distancing and everything. And they do everything that they had to give, and they do the follow-up as usual for this family. When the committee of workers, there is another case of figure when the committee of workers go for the visit, and if that committee of workers is not well equipped with the PPE material, that person should do everything that he can do without wearing the PPE. So they need to keep maintaining the social distancing, do the education for hygiene, but they are not going to perform any actions directly for this family. And they will assess with respecting the social distancing, and then they will inform the health facility around to let them know that there is a potential case and see what they have to do, and maybe the health facility will apply the protocol that is ongoing in that community for COVID-19. In this era of COVID-19, we cannot forget about the children with special needs, because we know that sometimes they are prone to develop some pathologies and contract some pathologies from the caregivers. Sometimes they have underlying conditions that put them at risk. And we have emerging data that show that there is a potentially higher risk of disease, of severe disease in these children with intellectual or developmental disability. For CDC case surveillance data, 22% of children 0 to 17 with disability were hospitalized, compared to 1.6% of children without disability, which is a lot when we do the comparison between those two populations. It's like 20 times more hospitalization among those children. So we need to pay special attention to those children, even for COVID-19, because they are at higher risk because of the caregivers. What about breastfeeding and COVID-19? I think that Dr. Taina talked a bit about that, because breastfeeding and COVID-19 can be a potential risk for the baby, because mostly when the mom is sick of COVID-19. 20 mothers had breast milk samples tested for the presence of COVID-19 of SARS-CoV-2 RNA particles by PCR. 7 of them had children with COVID-19. Of the 20 mothers who are breastfeeding who were tested, 18 were negative. 2 had positive results. Is it a contamination from COVID-19? The question is still remaining. So breastfeeding, we need to continue the education on breastfeeding, because the moms, they need to know that they can transmit the coronavirus to their child, but they still need to breastfeed the children, because breastfeeding is very important for their children. So the education must continue to apply the best practice in terms of breastfeeding from the moms, and avoid disruption of breastfeeding for children, and also avoid contamination of newborns with mom with COVID-19. So some action from breastfeeding mothers, for breastfeeding mothers in terms of COVID-19 protection for their children and for themselves. Practice respiratory hygiene, including during feeding. If they have respiratory symptoms such as short breath, they need to use their mask, they need to wear their mask while breastfeeding, they need to wash their hands. So they are going to continue to apply general hand washing practice. They need to routinely clean and disinfect the surfaces that they are touching at home. And if they are severely ill for COVID-19 or suffer from other complications that would prevent them from breastfeeding, they can still express the milk and still providing breast milk to their children. If they are too unwell to breastfeed for their children, they need to talk to the community of workers and see if they can find any other way to feed their babies that is suitable, that is good for their babies. Some action for the health facilities and the staff. They need to continue with education. They should continue to promote the importance of breastfeeding. And if the mom with the baby, if the mom cannot breastfeed the baby, they need to apply all the protocols that are related to breastfeeding in the hospital. Mostly mom and kids should remain together during the time that they are staying at the hospital. They should remain together, they should continue the skin contact, and they should encourage that mom, if ever she cannot breastfeed in the moment, to continue this contact so she can start breastfeeding as soon as she can. Counseling and psychosocial support should continue at the hospital, and they need to keep applying the breastfeeding protocol that are being applied at the hospital they are working with, or at the facility they are working with. In Haiti, we continue to encourage the mom to breastfeed their babies at the hospital, and we are trying to keep the place safe so the mom can understand that even in this era of COVID-19, breastfeeding is still the best alimentation for their babies. So just a reminder for the prevention in case of COVID-19, keep hand washing, avoid contact with other people, maintain the social distancing of 1.5 meters, and make sure that the kids are still vaccinated for the calendar of the country. For example, in Haiti, we do have this fear from the population. They fear of taking the child to the rally post for the vaccination because they think that things could happen. So we need to reinforce this to make the family understand that immunization is still the best way to protect their kids in this era of COVID-19. So we continue with the prevention with the kids. Cough hygiene, they need to know where, how to cough, when to cough. Like you can see on the pictures, they are all coughing in the elbow. Excuse me, I can't find the right words. So they need to cover their cough. So we need to continue with the education. And for the caregiver, the healthcare personnel, we need to protect them with all PPE that we can have. They will use the N95, they will use the face shield, the gowns and everything, and apply all the hand washing and everything as prevention. They will continue to do that, but we need to keep them safe by distributing the PPE materials. In conclusion, we have a relatively fewer cases of COVID-19 among children. It's evident with the statistic that we had presented at the beginning. Most cases in children result from household exposure. Direct child adult transmission is very weak. We identified some protective factors that keep children from getting COVID-19. The clinical manifestations are very polymorph and mostly similar to those in adults. And we have the multi-system inflammatory syndrome that can be very, very complicated to handle within children, leading to the Kawasaki disease or any shock syndrome. We need to pay attention to this. As of today, there is no specific treatment. We have general protocols, and usually they are suppurative protocols, and which means that the prevention is the key for COVID-19. Here are the references that we used, and I thank everyone for their patience. So thank you very much again, and if you have questions, we are available.
Thank you very much, Syndie, for this comprehensive presentation, and thank you to Dr. Taina as well. We have a couple of questions in the chat. I wasn't sure how much time we have, so I answered at some extension, but if you could complement. The first one was from Julia.
Okay.
Yeah, what is the percentage of population that is less than 18 in these countries? Overall, we know that is 20% in the global population, but could you give us more, what is the percentage, for example, in Haiti that are?
In Haiti, the population is pretty young. So I think it goes a bit over 20%. It's around 22 to 25% in Haiti. So the population is relatively young. So
Claudia and Syndie, and thank you so much for this presentation, Syndie. This is so interesting, and it's really been great to listen and learn from you. So the question was regarding one of the earliest slides, because we were seeing that it was around 2% or less of COVID cases were children under 18. But in those specific countries, I believe that they have generally older populations: Italy, Spain, United States, etc. So that's exactly more what the country was referring. That's what the question was referring to.
Yes, they have these numbers because they are, for example, Italy is relatively very old population, and in Haiti we are very young. We have a very young population. So it's less than 2%. For Haiti, it's the confirmed cases in Haiti. For example, here you can see on the slide that the confirmed case from 0 to 19, it goes it's around 2.2% for Haiti. But we should also say that the testing in Haiti is very low as well compared to this population. So this is the number that we have for Haiti.
I think definitely where you go, Julia, is correct, that assumption. If we have a population that are, as I mentioned, is bigger, the percentage of young population,
Yeah.
we will expect that you will find more cases in that population compared to the countries where
Exactly.
the populational pyramid is more on the top, is inverse, the pyramid. But definitely the point is we need to look at more data, continue collecting the data to be able to really have more clear information, because it was with the second question actually that the Kumusa did. I don't know if Kumusa, you want to ask the question directly. I just cite something that I know about the CDC. When we were doing this presentation, we find the cases, but I don't know if you want to rephrase the question again. I think it maybe she's now, connected now. Well, the question you could see in the chat was, is a weak transmission for children in all ages, or are some ages that can transmit more? According to what they find in the CDC, when more than 2,000 cases were observed, the transmission is the children that get sick, were more among teenagers. Between 16 and 18 years old, it was 1/3 of the population. Taina or Syndie, if you want to add anything else compared what you have seen.
Oh yes, thank you very much. Like we have said in Haiti, that we saw that, and we saw that in the presentation, that children are really bad transmitter. And like the CDC proved, children older, between 15 to 17, or also there are data from 10 years old to older, that they are more potential transmitter than young children. Children like infant or less than 10 years old are pretty bad transmitter for COVID-19.
Thank you. If anyone have any other question, we still have 5 minutes. Okay, if we don't have more questions, really, we appreciate on behalf of CMMB, all the participants. We know also we have participants who were not from CMMB. Thank you very much for joining us. Your participation keep us motivated to continue working and standard information and knowledge on what we are doing. Thank you very much, and with this we will conclude the presentation.
Thank you.
Thank you.